بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Dear students, it's my pleasure to start with you the lecture of speech and language. Let's start with a few definitions. The definition of speech. Speech refers to the actual sounds of spoken language. It is the oral form of communication. It differs from language, as the language refers to the whole system of words and symbols, either in written, spoken, even in gestures and body language. This is used to communicate meanings. This is language. Articulation is enunciation of words and phrases. It is a function of organs and muscles innervated by the brainstem. So this is a form of just enunciate the words and the phrases by the tongue, the vocal cords, the lips, the glottis. This is the articulation. A phonation is the production of vocal sounds without word formation, just like screaming, like any sound comes out from the vocal cords, but not without any word formation. So the speech is spoken or expression ourselves by spoken words that has meaning, and express yourself by these words. But language, it's wider than the speech, because you can use the writing to express yourself for communication. You can use gestures or your body language to express yourself. So let's now go to the speech anatomy. We do have the cortical speech centers, peripheral neuromuscular control of speech, and the coordination of speech. Let's start with the cortical speech centers. We do have sensory, motor, and the communication between the sensory and motor centers. Let's start with the receptors or receptive centers or sensory centers. First of all, the eye, the visual centers. We will start by the cortical primary visual center. It's area 17. This is for reception of visual stimuli, just to receive the visual stimuli. You don't know the meaning now or recognize what is this stimuli, just to receive it. The secondary visual center is area 18, recognition and giving a meaning for the received visual stimuli. It is an area around the area 17, which is a primary visual center. This is the secondary visual center. The tertiary visual center, or area 19, is responsible for storage and recall of visual images. It's also around the area 18. Another important area, it's numbered 39 by Brodmann. It's for recognition and recall of a written or printed language. It's in the angular gyrus. Angular gyrus is in the parieto-occipital region. Continue with the receptive centers or sensory centers. The auditory centers. The auditory also is a primary auditory center, area 22, for reception of auditory stimuli in the superior temporal gyrus. Secondary auditory center, it's area 41. This is for recognition and giving a meaning for the heard sounds in the superior temporal gyrus. Tertiary auditory center is in area 42 for recall of sounds previously heard. It locates also around area 41. So both of them in the superior temporal gyrus, and one of them for recognition and giving meaning, and the other for recall of the sounds. Wernicke's area is mainly area 22. In the most of literature, most of the books, it's an area 22. In some, in some literature, in some studies, it's area 22 plus area 39 and 40. It's responsible for comprehension and speech fluency. Let's go to the motor centers. We do have the main area, which is Broca's area. It's an area 44 and 45. Both of them are the Broca's area. It's a cortical motor center for speech production or production of spoken words. It locates its location in the posterior end of the inferior frontal gyrus, in front of the face area, which in the motor area, which is called the Brodmann A4, Brodmann area 4. Exner's area, it's concerned with the execution of written speech. It locates in the posterior part of the middle frontal convolution. It's not in the same level of the Broca's area, because Broca's area is in inferior frontal gyrus, and this one is in the middle frontal gyrus or convolution. We call it Exner's area, and Brodmann classification or Brodmann areas. It's a part of the area 6. Another areas, which is called association centers, language formulation area, area 37, is the cortical center of language formation. Its function is association between the receptive, which is the sensory, and executive, which is the motor center of speech. It locates in the occipital-parieto-temporal region, but in another place, this area is fused in the fusiform gyrus or occipital-temporal gyrus, not occipito-parieto-temporal. It's occipito-temporal gyrus, and it's responsible for processing of color information, face and body recognition, word and number recognition. This is area 37. There are other connections between the same hemisphere, in the areas in the same hemisphere and the other hemisphere. It's called subcortical association fibers. Connect various areas in the cortex in the same hemisphere together, and also communicate with the corresponding cortical areas in the other hemisphere through the corpus callosum. This diagram shows the language formulation area. As we see here, area 44 and 45. These are the areas for speech production or motor areas. Also, the area 6 or Exner area, Exner center or area. This is area 22, which is the Wernicke's area. Area 41, 42 for hearing. Area 39 for giving a meaning for the seen numbers or written or printed words. And the area 17, 18, 19, these are for the vision. These centers for the vision, perception and recognition and recall. Okay, here is the Broca's area, and it is in the front, 45 and 44. Exner area, area 6. But mainly we talk about the Broca's area and the Wernicke's areas. This one is a sensory area, area for speech, and the Broca's area, motor area for speech, and this arcuate fasciculus that connects the sensory area with the motor area. Okay. Also, phonation and articulation. If you send information from the brain to start speech or to write something, you have to have the pathway from the brain to the brainstem, then to the peripheral muscles for writing or the muscles for speaking, like tongue, glottis, lower lip, and in the same time you need air from the lungs to go through the glottis and the vocal cords to continue the process of speaking. We used to speak the speeches usually during exhalation, not during inhalation. So the exhalation is prolonged during speech, so you produce sound. Okay, so all of these are important for production of speech. So we have the central centers in the cortical centers in the dominant hemisphere. We have to remember that the dominant hemisphere is in the left hemisphere. This is dominant hemisphere. In all of the subjects who use the right hand or right-handed people, but even in most of the left-handed people, the left hemisphere is a dominant hemisphere. Okay, so if I see something or hear something, I got the information to go to the centers for hearing and for seeing or for vision, and after that I process it to the area responsible for each one of these sensations. If I see say an apple, okay, it goes to the cortex, area 17, then 18, then 19. From these areas through the area 39, okay, the information goes to the area 22, which is the Wernicke's area, and through the arcuate fasciculus, the information travels to the Broca's area to make execution of what is the meaning of this apple. I have to eat it, I have to give it to somebody or something like that. If I hear the sound, like he's saying that there is I've seen a candle, he said to me, somebody said to me, what does it mean, the word candle? You can see this is a candle, there is light, something like that, by hearing. And after I got the information or collected my information in the brain, I can say it's a candle, or this is a watch, whatever. So that I have to have stimulus from outside, like hear something or seen something. After that I have to process it, and after that all these information by its meaning goes to the Wernicke's area. Through the Wernicke's area and the arcuate fasciculus, this information goes to the Broca's area to start what you want to do, either in written or in a spoken expression. Okay, we finished the first one of the anatomy of the speech and language. Now the peripheral and neuromuscular control of speech, phonation and articulation. That means the movement of the jaw, lips, tongue, palate, larynx, and respiratory muscles. The motor fibers descends from the lower part of the motor cortex in the pyramidal tract, decussates in the medulla, ends in the nuclei of the cranial nerves 5, 7, 10th, and 12th in the pons and the medulla. These nuclei innervate the jaw, the lips, the palate, the larynx, and the tongue. Also, pyramidal fibers innervate the diaphragm and the intercostal muscles. The third thing is coordinating the speech or coordination mechanisms. You know, the cerebellum and the striatum, the extramedial tract, are responsible for regulation of articulation. As I just mentioned now, 93% of population who are right-handed, the speech function is subserved by the left cerebral hemisphere, and more than half of the remaining 7% who are left-handed also subserved by the left cerebral hemisphere. The rest of people, speech is controlled by the right hemisphere. So mostly the left hemisphere is the dominant hemisphere. So let's go to the important thing, which is the disorders of speech and language. Let's start with aphasia or aphasia. It's an ability to formulate a meaningful speech. There is a motor aphasia or expressive aphasia, verbal or broca's aphasia. This is the first type of aphasia. The patient understands the spoken words and obeys commands. If you tell him just move your right upper limb, raise your hand, touch your nose, he can obey commands because he is understanding. There is no lesion in the comprehension or the sensory part of speech. The problem is in the motor part. Okay, the lesion in the Broca's area, in the posterior part of the inferior frontal gyrus, and the lower part of the precentral gyrus. Okay, nominal or amnestic aphasia, inability to name objects or subjects properly, although the patient knows their nature and value. I will give you an example. If you show him a key, he cannot say this is a key, but he can say that this is the thing that we can open the door by it. And if you show him a watch, he say, well, this is for to know the time, but doesn't know how to pronounce or to say watch. He cannot say watch. The region in the angular gyrus or superior temporal gyrus of the dominant hemisphere or dominant hemisphere. The other type, the important type of aphasia is sensory or receptive aphasia, inability to understand spoken or written words. If you told him, what did you do today? He will say, my name is Muhammad, I am 12 years old, but he doesn't obey, he doesn't know what did you say to him, but he can talk fluently, but words used inappropriately leading to neologism. He got a new language for himself. A lesion in the posterior part of the superior temporal gyrus and the parts of the adjacent parietal lobe of the dominant hemisphere. Jargon or central or syntactical aphasia. It is a form of severe receptive aphasia with failure to produce correct words leading to neologism and paragrammatism. The region here in the left temporoparietal region. Word deafness, inability to understand spoken words. Speech production regarding and reading and writing are normal, but he cannot recognize or understand the words, spoken, not written, spoken word. The lesion in the posterior part of the superior temporal gyrus of the dominant hemisphere. So the problem in the spoken word. Word blindness, he cannot see. Inability to recognize written words or letters. If you give him a piece of paper with something written, he can see the paper but cannot recognize what are the words or letters written on this paper. The region in the angular or supramarginal gyri of the dominant parietal lobe. Alexia with agraphia, visual asymphonia, inability to read or write spontaneously. The region in the left angular gyrus. Agraphia, inability to write. This is a form of expressive aphasia. The region in the external area. Calculia, inability to calculate. If you give him, just a simple something to calculate. Give him 5 plus 2, he cannot calculate. This the region in the left angular gyrus. Amusia, inability to appreciate musical sounds. Global aphasia, impairment of both expression and the comprehension of speech. So it's massive affection of this area. The lesion in the dominant hemisphere involving the both Broca's and Wernicke's areas. Dysarthria is another form of speech abnormality. Dysarthria is an impairment of articulation due to the disorder of the neuromuscular mechanisms responsible for it. The muscles and neuromuscular junction are responsible for the articulation. So the causes may be bilateral upper motor neuron lesion, supranuclear, we call it pseudobulbar, due to pseudobulbar palsy. The region in the cranial nerves 9th, 10th, or 12th above these nuclei, not in the nucleus. If it is a nucleus, it will be the lower motor neuron lesion, and we call it true bulbar palsy. It occurs in cases of congenital diplegia, double stroke, multiple sclerosis, neuromuscular disease, motor neuron disease, or upper brainstem lesions. Spastic dysarthria is the result with the slurred speech due to upper motor neuron lesion. Spastic dysarthria with slurred speech. The same if it is bilateral lower motor neuron lesion of the cranial nerves, the same cranial nerves, it's true bulbar palsy. As in case of diphthetic polyneuropathy or neuritis, bulbar poliomyelitis, and progressive bulbar palsy. Extrapyramidal lesions, as I think some of us have seen patients with Parkinson's disease, and you may notice his way of speaking with rigid dysarthria and slow, quiet, and monotonous speech. The patient can make you sleep during conversation because he will say in the same tone or slow and a quiet, monotonous speech. He will say, "My name is Mohammed. I went to the hospital today with my family." So this is the way of speak of this patient with Parkinson's disease or extrapyramidal lesions. Cerebellar lesions like multiple sclerosis, hereditary ataxias, cerebellar and cerebellopontine angle tumors, or anticonvulsant toxicity. The speech is ataxic dysarthria, slurred, explosive, staccato, or scanning. He will say, "I would go to the hospital today," like this. It's slurred and explosive staccato or scanning speech. In case of muscular disorder or muscle disorder, like myasthenia gravis, slurred with the nasal tone and hoarseness increase with fatigue. You will hear nasal tone with this patient and hoarseness due to fatigue. Myotonia may lead to a strangled speech due to stiffness of the tongue. Facioscapulohumeral muscular dystrophy. These patients had the inability to pronounce labials. What's labials? BMW. B, you can pronounce B by use of your lips. So P, you cannot pronounce it if you have a problem in the muscles of the lips. In case of facioscapulohumeral muscular dystrophy, W, also you cannot pronounce it. Wow, very difficult. M, meme, you cannot pronounce it. This patient with facioscapulohumeral muscular dystrophy. In case of oral lesions like a cleft palate or tongue tie, also it's a form of dysarthria. Okay, aphonia or dysphonia. It's from phonation and loss of the ability to phonate, but the patient can talk in whispers. And the causes are laryngitis, tumor or paralysis of the vocal cords, or hysterical if the patient trying to escape from a stressful situation, especially females. The patient ability to phonate when coughing is the clue to diagnose the hysterical aphonia. If you ask this patient to cough, he will but he cannot phonate. Okay, this you can distinguish that from the organic, the functional from organic. If he can cough, this is the functional or hysteric. Mutism is a total inability to speak. Okay, what are the causes? Psychosis or psychotic, like in schizophrenia, hysterical mutism, extreme depression or mental retardation, akinetic mutism as in upper brainstem lesions, deaf mute, the child who was born by deaf cannot acquire speech because he cannot hear. So you have to hear first to acquire information and acquire speech to put some information or over information to use it after that. So if the patient cannot hear, how can he speak? Other disorders of speech, polylalia, increasing rapid repetition of stereotyped words or phrases. If the patient is repeating the same statement in an increasing manner, but this is by himself, not repeating. Like he was saying, أنا رحت المدرسة النهاردة، أنا رحت المدرسة النهاردة، أنا رحت المدرسة النهاردة، أنا رحت المدرسة النهاردة. Okay, post-encephalitic Parkinson disease, Parkinsonism, or pseudobulbar palsy of vascular origin can cause this type of speech disorder. This lalia substitute one letter for another in many words. Like the child says first, not thirst. First, not thirst, by F, not by TH. It's substituting letters for another one. Echolalia, it is involuntary, parrot-like, زي البغبغان, repetition of words or phrases spoken in front of him. He is repeating what you ask him. انت اسمك ايه؟ يرد عليك يقول لك ايه؟ انت اسمك ايه؟ انت اسمك ايه؟ where are you from? Where are you from? Where are you from? He will repeat after anyone who speaks in front of him the same statement again for many times. The region in the temporoparietal region. Stuttering or stammering, this is the abrupt interruption of flow of speech or the repetition of sounds or syllables. It's common in the children who were born left-handed and the family enforced them to use the right hand. This is in males more than females, 4:1 as a percentage. The rate and the ratio 4 males to 1 female. In this case, the child will say رايح فين؟ أنا عايز أجيب كذا. He can in the start or during the speech. So don't enforce the child to use the right hand if he is left-handed. This is all, and thank you very much.